So we started up in 1981, and of course the Reagan landslide gave us a Republican Senate, a divided government politically, and a number of new proposals to block grant Medicaid, cut domestic spending for health programs, reduce taxes, etc. Now, does that sound familiar? Because it's happening again today. So NAPH was, in fact, handed a full platter of issues when we were created. And with the support of our own members initially and with other organizations, we were able to hold off the dismantling of Medicaid at that time, but Congress did agree to give states significantly greater flexibility in designing Medicaid payment methodologies, which in turn enabled us to include language requiring states to, and I'll quote, take into account the situation of hospitals serving a disproportionate number of low-income patients with special needs. In other words, the DISH provision that you've all come to know and love was, in fact, the very first legislative achievement of NAPH, and we wrote it into the Medicare statute in 1982. It took several years of litigation and further statutory amendments to actually see these provisions implemented, but I added this up the other day, and I think conservatively those provisions and related supplemental payment mechanisms have resulted in over $400 billion in payments to NAPH members and similar hospitals around the country. So in sum, in 1981, and that applause was for yourselves because this could not have been done without the aggressive lobbying and advocacy of all of our members together around the country. So we did have a national voice right from the beginning. We had to counter the notion that Medicare and Medicaid had ended the need for public hospitals. We had to focus on improved funding for the safety net. We had to develop a community of peers to lend one another reassurance and support and to convince yourselves that no matter how daunting your situation was, someone else actually had it worse. You may remember the Elliot Roberts Prize that we would give out each year because after everyone else had spoken, Elliot would get up and describe his situation at big charity in New Orleans and everybody would feel better. And we also paid special attention right from the outset to the disadvantaged populations that our members served. In fact, Charlie Rangel said early and then again often during the course of NAPH's dealings with him over the years that NAPH is the only hospital association I know that talks more about patients than hospitals. So what's different today? Let's fast forward a little bit. Well, for one thing, instead of the Kellogg Commission, we have the 2000 report of the Institute of Medicine, which was called America's Healthcare Safety Net, Intact but Endangered. And that report found, and I'll quote, the funding and organization of the safety net have always been tenuous and subject to the changing tides of politics, available resources, and public policies. Despite their precarious and unstable infrastructure, these providers have proven to be resilient, resourceful, and adept at gaining support through the political process. Today, however, a more competitive healthcare marketplace and other forces of change are posing new and unprecedented challenges to the long-term sustainability of safety net systems and hold the potential of having a serious negative impact on populations that most depend on them for care. Fast forward yet again to 2011. Health reform has finally been enacted, but has not yet gone into effect and is under attack on many fronts, politically and in the courts. But could we answer with that uncertainty some of the core questions posed earlier any differently today? Are there policymakers today who believe safety net hospitals and health systems will no longer be needed when health reform is fully implemented? Are the DISH and other supplemental payments you depend on today reliable and sustainable, or are they going to be reduced or eliminated? Will they need to be replaced with something else in the future? Do you need to look for viable alternatives? Do your CEOs and other senior management, your chief medical officers, your chief nursing officers and other clinical leaders, your board members, and other key stakeholders still need a national community of peers to share your hopes and plans and compare your wounds and war stories? Do your patients still need a national voice? How enfranchised are Medicaid recipients today, and not to mention the uninsured and underinsured, including those who are going to become eligible for coverage in 2014, as well as those who will not, and there are many, many millions of those. Will there still be many undercompensated community-wide services that will need to be provided? What do you think? In addition to all of that, will you need advice and assistance from wise and knowledgeable national leaders who will help navigate the complex currents of healthcare reform? Will help you improve quality while also increasing efficiency and reducing costs. Will help you adopt new approaches to integrated healthcare delivery systems, accountable care, population health, comprehensive care management for the chronically ill. And finally, will you need help in navigating the immediate crises of deficit reduction and debt ceiling extension, which bring extreme peril to Medicare and Medicaid, even as we look at the longer picture. I don't know if you remember David Brooks in his New York Times column about a week ago reminded us that President Eisenhower said in his farewell address that the country must, quote, avoid the impulse to live only for today, plundering for our own ease and convenience the precious resources of tomorrow. We cannot mortgage the material assets of our grandchildren without risking the loss also of their political and spiritual heritage. So I would submit to you, we need to take the current debt crisis and deficit reduction activities seriously. Everybody agrees on the need to do that, and the American public is going to insist on extracting many pints of blood from the federal budget in the very near future. So for all of these reasons, I do believe that NAPH will still have a role to play in 2011 and beyond, and that role will continue to be grounded in concern and compassion for the most vulnerable among us. Without even mentioning health care, Martin Luther King Jr. summed up what I think is NAPH's ongoing mission in just one sentence in his acceptance speech for the Nobel Peace Prize in 1964, when he said, "I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education and culture for their minds, and dignity, equality, and freedom for their spirits." NAPH will continue to be needed to ensure that this right to dignity, equality, and freedom includes health care and, even more important, good health. So now it gives me great pleasure to pass the podium on to Bruce Siegel. I can't tell you how delighted I was when Bruce's name first cropped up on the list of potential candidates for this position just about a year ago today, maybe even a little longer than that. I couldn't imagine a better person to take over and guide NAPH into the future. He has all of the characteristics we are going to need, many of which I lack in terms of his attention to the clinical and operational needs of safety net hospitals and health systems. He's a good person. He has an even better wife. They make a great team, and I just am delighted that it makes me feel better about the last 30 years to know that someone of Bruce's caliber is willing to take on this challenge in the future. Now, I faced a dilemma in reaching this point, and we're going to be having this. This is going to be a sort of rolling transition over the next couple of days. There are going to be a lot of lies told tonight, I suspect. But what exactly do I pass on to Bruce? It can't really be a gavel, because a gavel is for our board chair. A long time ago, we gave Charlie Rangel a stainless steel urinal bedpan with a nice silver plaque attached that had his name on it and praised him. Well, as all of you know, they don't make those anymore, and it's very hard to engrave, thin plastic with anything meaningful. And so what I came up with this morning, and what I am going to pass on by way of the mantle to Bruce Siegel, as well as the podium, is the wine list.
What can I say? Larry knew exactly what I needed. As my wife Mara over there, hi Mara, wave, can attest to, I'm the kind of guy who still thinks that wine should come in a box. So maybe NAPH is not in the best hands necessarily going forward in all ways. But I think it's important, and we've done this before, but I think it's important we do this over the next couple of days, that we do thank Larry for all that he has done to make this a better nation in many ways and to really bring the promise of better health to all Americans. He has an incredible amount to be proud of, and we can't thank him enough for his energy, his vision, and his spirit, which, just as you saw now, even in the toughest times, sees that opportunity beckons. And I think these are going to be figuratively and as well as literally big shoes for me to fill. So thank you for handing NAPH over to all of us in such fine shape as we prepare for the battles ahead. I also have to give thanks to all of you who are here today. Many of you, most of you, come from member health systems. Others of you are good and often longtime friends of NAPH. You know this is an important gathering for us. You've heard that. We're here to honor 30 years of supporting our members' missions. We're also here to collaborate and to learn from one another as we figure out how to provide the best health care in some challenging times. None of this would have been possible without our sponsors, who generously made much of this meeting possible. Here they are. I'd ask you to give them a hand as well. Feels like one of those NASCAR cars, you know, with all the ads on it there. Our gratitude also goes to our chair, Dr. Calhoun, our executive committee, and our board for extending me the privilege, and my gratitude, for joining you in this important work. I'm also thrilled to have the support and the warm embrace of the wonderful professional staff at NAPH who welcomed me to this new role. Thank you so much. And finally, thanks to Mara, to Orly and Leela, my beloved family. I thank you in advance for your patience, for without your support and your forbearance, I could not do this job. Today, I also need to greet 3 new members into NAPH. There are St. Luke's Health System in Idaho, the University of Mississippi Healthcare, and Central Health of Austin, Texas. It is fantastic to have you here, and thank you. All of you have joined us at an interesting time. It's a time that holds tremendous promise and perhaps great peril, as Larry mentioned. The passage of the Affordable Care Act just 16 short months ago was a signal event for the safety net. It promised a huge expansion in coverage with major steps towards a day when maybe everyone living in this country would have good, reliable care. This resonated with the safety net leaders, who supported it despite serious reservations about some things in the bill. Many were concerned and are getting even more worried about reductions in disproportionate share hospital funding. These cuts ignore the fact that millions of people, including undocumented immigrants, were left out of the Affordable Care Act, and that Medicaid is paying hospitals and doctors less and less in many states. All of you also worried about, and we also worried about, financial penalties for things like readmissions that could wrongly punish the providers who, with the least resources, serve the poorest people with the fewest social supports. Despite these reservations, the safety net, for the most part, and NAPH in particular, supported the Affordable Care Act, and did so loudly. I believe all this was due to the hope of equity promised by reform. For years, our health systems have struggled to achieve better health for all, despite glaring inequities in dollars and human capital. You worked to ensure a place at the inn for the sick, and to train health professionals who could meet this calling, be it in Birmingham or Boise or Boston. The Affordable Care Act seemed finally to be action that got us a lot closer towards the promise of an even playing field in health care for Americans. But that promise now seems just a little bit dimmer. A heartbreaking recession lingers with all the human and fiscal damage that entails. Stubborn unemployment and depressed property prices have deprived us and our governments of trillions of dollars.